In this video, we will discuss study design. We're now going to look at how to critically review the literature to begin this discussion. Study design is, the main goal is to reduce bias. Bias, the definition of bias is systematic error. Now that's the definition in terms of evidence-based medicine. Bias doesn't mean prejudice or anything like that. It means systematic error. An example of systematic error is the Goldman tonometer. The Goldman is kind of the gold standard of measuring intraocular pressure, yet it has a defect or a flaw, a bias. If your cornea is thick, it will register your IOP as higher than it really is. If it's thin, it'll be the other way around. So it has a bias, a systematic error. And we want to design studies so that they don't have systematic error. The ideal situation is to be able to have a subject and measure them under one condition and then pretend like that condition, and then make it so that that condition never happened to them, and look at them under another condition and compare the two conditions. Really, only God can do that, and we are just not able to do that. It's not possible. As soon as you expose a person once to experimental measurements, they become a different person in a sense. It is not comparable to measure a person at baseline and then measure again after treatment. You'll see some study designs where they measure a person before they give any treatments, and then they give the treatment, and then they look to see if there's a change. The idea is you use the person as their own control. This is a terrible, completely something design. It's just bad, because a person, when they're measured the second time, is just different. They have, time has passed, their condition may have changed, they have practice on the outcome measures. It's just not possible to do that. So what are the alternatives? How do we design a study so that it's not biased? Well, if the person has a chronic disease and the treatment does not cure them, you test one condition, have a washout period, test another condition, and then for another group of people, you reverse the order where they're tested on treatment 2 and then tested on treatment 1. So you balance the confounding effects of time and practice. Now that sounds pretty similar to the one we just said was really bad, but it's a reasonable approach when you when you have a person with a chronic disease and you want to see how they do under two different conditions. So this method is only for chronic disease. It doesn't work if the person doesn't wash out. So if you did two treatments right next to each other, the second treatment might be influenced by the effects of the first. You don't want that. You want a situation where the person is returned to baseline at the start of the second treatment, and then you measure them. And the other thing you look at to see if there's an order effect. Now, if one treatment responds differently after following the other, in other words, it's kind of an interaction there. It depends on which treatment went first. If that's the situation, this is not a good design. and you do your analysis just based on the first order. You don't consider the crossover treatment. So that's one way of doing it. Perhaps the gold standard, though, is the randomized controlled trial. Whether it's acute or chronic disease, people are randomly assigned to one condition or another. There are no repeats. You can take baseline measures to kind of see where people are at the beginning and control for baseline differences, but the key is that you've randomized them. And that's the best design. It's an expensive design. It has limitations. We'll talk about them in a minute. A third type of design that's really pretty good too is called a propensity analysis. People are statistically paired on all relevant known variables that are related to the outcome, and then the different treatment conditions are compared. This is not a real popular methodology in optometry yet. It's very popular in the medical community. It will become more and more accepted because it's a reasonable approach that has a lot of good characteristics to it. So there are a number of we've called the randomized controlled trial the gold standard. And the National Academy of Medicine, when it sets up its guidelines, and the AOA, when they do their guidelines, when they give their recommendations, not only they talk about the strength of the recommendation, but they talk about the strength of the evidence that went into it. And there are generally 4 levels, A, B, C, and D. And these are, well, level A is a well-designed randomized controlled trial. This is the best data that's out there. There's systematic reviews, meta-analyses. Or if we're talking diagnostic studies, it's those of relevant populations with a validated reference standard. The randomized trials are sufficient numbers, often multi-centered, that are really good designs. Now, B also includes randomized clinical trials, but they tend to have weaker designs. They're single center. They are smaller numbers of people. They also have cohort studies that, in this case, it says retrospective, but mostly the cohort studies in B are prospective, where you find a group of people and you follow them over time and you see if they develop a disease, and then you can go back and look at their initial characteristics. Again, diagnostic studies, level grade B, generally have more restrictions on the population. Level C are studies with a pretty strong design, but with some real limitations of bias. For example, a non-randomized trial, a case control trial, here it's more retrospective than prospective, a retrospective design in which you find cases, people with, say, glaucoma, and then you try and match them to people without, or you collect data from people without glaucoma, and then you go back and you try and figure out what was different in their growing up that would lead to glaucoma. Then finally, the lowest level is cross-sectional studies. Those are like surveys, a point in time. The outcome and the cause, really, cause and the effect are collected at the same time, so it's kind of hard to tell which is which. You get correlations mostly. Also, there are case reports or case series, which talks about individuals or an individual doctor's experience with a particular type of disease, and it only talks about, for example, glaucoma patients. and some of the things that have been learned with that. Reviews of the literature, position papers, expert opinions, that sort of thing. So those are the level of evidence that is that we consider. And you want trials to be as high in that list as you can. So let's talk a little more about randomized controlled clinical trials, the gold standard. They have to be registered at clinicaltrials.gov. And this is a site where if you're going to do a study, you sign up, give a brief methodology, and it's a place where you can recruit patients. People can go to clinical trials and see which studies are actively recruiting, and if they have a particular cancer or some sort of disease, they can call and see if they can get into the study. This was initiated for recruitment, but it was also initiated because drug companies or medical device companies would run a study at 5 different universities and then publish the ones that they liked and ignore the others. In clinical trials, you have to register for the study and then complete it and give your outcomes on that. So you can't cherry pick. And the FDA will not accept information for approval, drug or device approval, that hasn't registered at clinical trials prior to starting the study. Another, or one of the, obviously a core feature is randomization. Subjects agree to participate in the study, and then they are randomized to a treatment. So those people on clinical trials, they call up and they say, I want to be in the study, and they say that's fine, but they're still randomized to one group or the other. A control group is also a necessity. A control group is required to provide a reference for the effective treatment in a comparable group that only differs by the treatment that's given. So oftentimes the control will be a standard of care. It's not necessarily a placebo where you get nothing, but you might get what is the current best known care, and then does the treatment group add to that and do better? There are limitations on randomization. Selection bias is the big one. Only people willing to be randomized enroll. And so think of the difficulty of recruiting sometimes. Imagine a mom brings her kid that's myopic and says, hey, doc, or the doctor says, hey, mom, we have this great new method of controlling your growth of your child's myopia, and we want to do a study, and a randomized controlled study, because that's the best kind. So we would like you to join the study, and your child will either be randomized to get the new treatment or be in the group that gets the standard of care. And oh, by the way, this is a 3-year study, and at the end of 3 years, if your child's eye is grown and one treatment is better than the other and you didn't get that one, it's too late. The damage is done. And so it's hard to recruit for that kind of a study because people want to get it. Now, if it's just a few weeks or you try something and it comes out, well, people are more willing to be in that kind of a study. We've talked about the Cochrane Review before, and it has a set of formal procedures to assess the risk of bias. There are a number of sources of risk of bias in observational, that is non-randomized trials, and those are listed in a paper that I gave you on Moodle. The methods of assessing risk of bias when reviewing randomized trials include allocation sequence has to be adequately generated. So when you're writing up the paper and trying to get into a Cochrane meta-analysis or just a Cochrane review, you need to clearly state how you assigned groups. So saying that you took the first patient was in group 1 and the second patient was in group that came to your office was 2 and the third was in group 1 and the fourth was in group 2, that's not an acceptable method of randomization. So you need to clearly lay out how you did it. A second thing is allocation concealment. The system has to be designed in such a way that the doctor cannot predict which group his patient is going to be in, because you don't want the doctor routing patients to a particular treatment. This is often done by having a study coordinator assign the treatment so that the patient comes in, signs the consent, has their initial exam, and then when the doctor's out of the room, the study coordinator comes in and assigns the treatment and gives them the drugs or whatever they're testing. Another thing that they look at is masking of participants. That is, does the subject know which treatment they got? The personnel, the doctor, they try not to let the doctor know which it is. And the outcome assessor, that's the statistician. You don't want that person to know and then maybe somehow biased by being aggressive on various different types of statistical analyses. So this is masking, and you evaluate this study based on that. Another big one, and particularly in clinical trials, is the handling of missing data. If you have a trial that's going on for a while, people are going to drop out or they're going to miss appointments. And what do you do about that? Do you simulate their missing data? Do you just drop the whole subject with missing data? Missing data can lead to bias because there could be a reason data is missing related to the treatment being tested. So, if you end up with only people who felt like the treatment was working, then the treatment is going to get a pretty good outcome measure. But all the people that dropped out said it didn't work, and their outcomes would have been bad, so the treatment may not have been effective. So missing data and considering how data is handled is a very important part of reviewing a paper. We've talked before about meta-analysis. It's a summary of several, usually randomized controlled trials on the same topic. The Cochrane database is in there, and it's a formal way of writing up the analysis as well as a review of multiple studies, so that it's actually computer-based, and when new studies come out, the review can be updated. So it's a pretty slick method. Limitations are that we update based on literature that's available. Sometimes there's a publication bias. That is that journals want to publish significant results. OVS, Optometry and Vision Science, just came out with a statement saying that they are committed to publishing negative results where there's no difference, as long as the test is reasonable. Also, sometimes a person who really feels like they know for sure what the answer should be, and they get an answer that's the opposite, well, they say, well, that contradicts my core beliefs, so I'm not going to publish it. That's a real problem, and hopefully that doesn't happen too often, but it probably happens more often than we'd like. Now, it's listed as a limitation, the fact that when we look at the studies, there are many different natures of the sample, but that's not necessarily a bad thing, as samples are different and the results are the same. It just shows that the result can be have more generalization. Another podcast here by Ben Goldacre, he points out the publication bias and is pretty down on medical literature. But it's not that he doesn't have a point, but it's pretty easy to be critical, and I think he's maybe a little harsh, but it's worth a listen to get his opinion. All right, let's look at some examples. Age-related macular degeneration. It's a condition that where your central vision is lost. And in a Cochrane meta-analysis, they require the provision of a plain language summary designed for the layman. So anyone can read this paragraph and get an idea of what they found. They didn't find much in terms of vitamins improving. They found a little bit of an effect, but it wasn't a great big effect. This one doesn't fit on my screen very well, but this is a single trial. The meta-analysis before, it looked at, they found 13 randomized controlled trials. 5 trials in the USA, 2 in the UK, 2 in Austria, 1 trial from other countries. And they say the trials found that supplementation with antioxidants and zinc may be of modest benefit people with AMD. Most of the patients came from one large trial that followed up participants for 6 years. The other smaller trials did not provide evidence of any benefit. And so this is the big trial, and there were 2 of these. ARED's trial, if you haven't heard of this yet, you will. And lutein and zeaxanthin and omega-3 fatty acids, they found some benefit. The conclusion and the relevance. The addition of lutein, zeaxanthin, DHA, and EPA, or both, to the AREDS formulation, the original vitamin formulation, in the primary analysis did not further reduce risk of progression to advanced AMD. However, because of potential increased incidence of lung cancer in former smokers, they eliminated one of the vitamins. Now, an important thing to consider in this one, when you look at the methodology or something to consider, who are the patients here? And basically, they were all patients that had AMD. And all of these studies in this one and the meta-analysis before, they were all patients who had AMD, and what they tested was their progression to advanced AMD. So they wanted to know if the supplementation would save a person's vision from getting worse. And there are biological reasons for this. It's not an unreasonable request. Okay, let's talk a little bit about observational studies. Basically, there are risk factors that accumulate over the life of you, and they lead to a disease. In the case of AMD, some of the risk factors are, one of the risk factors is this waste product that builds up in your eye called lipofuscin. It's a result of the visual cycle. When the rods and cone little discs are blown up by light, they go into the retinal pigment epithelium, and the RPE cells kind of recycle them. But some of the, if they're overstimulated or something, they don't get it all, then the excess goes into the lysosomes. And those store it, and you accumulate the storage of this waste product over time. So older people have a lot more lipofuscin than younger people. Well, over time, these little trash bags that are there start to leak. And this chemical in them, A2E, is susceptible to being oxidized by high energy shortwave light, blue light, for example. And the blue light oxidizes the A2E, and so there are oxygen radicals. So the idea is the risk factor are these oxygen radicals going around because they're going to bind to the mitochondria and then lead to AMD. And that's where the AREDS thing came in. They gave people antioxidants thinking they could maybe suck up these oxygen radicals and prevent them from leading to the disease. Well, we saw the randomized controlled trial in AREDS 2. There are other trials that are either cohort studies or case control studies. And the main difference is the cohort studies, there was one big one we'll look at in a second. It looked at people, they selected people early and followed them to see if they developed the disease. So they looked at specific risk factors, followed to see if they developed the disease. In the case of case control studies, you start with people that have AMD and look at a comparable group, try and make it a comparable group of people, not randomly selected, of course, not related in any way necessarily. I mean, they try and match on age and different things, but then they go back and say, well, were these people exposed to sun or something else like that that would lead to this, or did you take vitamins or whatever? And there are different things, but they differ on how they're selected. A cohort design is really a stronger design because you're following people. You have defined what variables you want to collect. In a case control study, you're kind of at the mercy of the medical record. A cohort study, though, is very expensive. It's long-term. It just costs a fortune to keep up with these people and not have a lot of missing data. Case control, on the other hand, is pretty cheap. You just go into your records, you find a group with the disease and another group without them, and you ask them questions about their youth, or you go back into the medical record and see what happened earlier. Prospective study subjects can be more comparable when you're selecting them because they haven't developed any particular risks yet or any particular disease yet. So you're just looking at all people are kind of similar. Missing data is a huge problem in case control because the records just tend to be very bad. So here's a prospective cohort study. It has a quality of B. It looked at genetic susceptibility, dietary antioxidants, and long-term incidence of age-related. And they gathered data from food frequency questionnaires and other things, and they followed them for 15 years. And they, let's see, when they first picked out people, let's see. Oh, it doesn't say. But these were probably people who had AMD, and then again they looked for advancement over time. And they also, in this case, they found that there was an advantage, a reduction of AMD if you ate fish and took lutein and zeaxanthin, and also if you had a high genetic risk. if you had a high genetic risk and you did these things, you were less likely to get AMD. A case control study, similar, reports the association between nutrient intake and related AMD. They looked at 161 AMD cases from 2 university hospitals and 369 population-based control subjects from a cohort study. And they used a brief questionnaire with 58 foods on it. And they looked at odds ratios and stuff. We'll get to that. And they found no association of cryptoxanthin intake and AMD. They did find that zinc and these other various things, vitamin B, were associated with AMD. And so they found some evidence with that. And it's quite common to find effects in cohort studies and case control studies. And then but they require being tested with a randomized controlled trial. And oftentimes those findings just go away. And that can be because of a lot of different reasons. But one reason is, again, you're looking at something and there's a lot of these observational studies. Just by chance, you'll find a few things that work. But when you test them again and chance is not in the equation when you randomize, then you don't find the results. And here's a cross-sectional study where they surveyed patients with macular degeneration, and they asked them questions about their lifestyle and ARED supplements and what they found. And patients with AMD recalled following the at least they recalled the recommendations of ARED supplementation, knowing that they should take antioxidants more often than other lifestyle changes. And they generally felt the recommendations were necessary and affordable. But, again, not so much was that a really strong design. Okay, in summary, when you're reviewing the literature, you should trust, but make sure the sample size is adequate. The best is a randomized controlled trial, especially those with larger samples. A propensity analysis with statistically matched samples that control for known issues. But be more skeptical and look for bias in non-randomized controlled trials. Cohort studies, case control studies, descriptive studies, and look and understand the bias, that there is a good chance there's bias there that's going to make these studies not quite so reliable. So you go to it with a little bit more skepticism. In this course, we replace eminence-based medicine with evidence-based medicine, as the podcast Bad Medicine has described. And so there will be a homework problem. You can check it out on Moodle, and we'll talk more about that there. You'll need to listen to a YouTube video, which is an ad for a supplement, and then decide whether or not you recommend this supplement to your patient based on the contents of the video ad and their argument for pushing this supplement. And does it apply to you? All right. Until next time.